So I will start with Dr. O'Neill. She's an assistant professor of neurology at NYU in New York and a specialist in multiple sclerosis and related neuroimmunological disorders. She completed her medical degree at Georgetown University School of Medicine and then residency in child neurology at Montefiore, also in New York, and a fellowship in multiple sclerosis at NYU. She's board certified in child neurology, and in her clinical expertise, she's engaged in research that explores the intersection between neuroimmunology, imaging, equity, social drivers of health, and really focused in improving outcomes for children and adults, young adults. So please join me in welcoming Dr. O'Neill today.
Thank you so much. Thank you so much for having me. I'm really so excited about SEQUINS and the Inspire webinar series, and very honored to be welcomed here today to kick us off for our first event. Share my slides. How does everything look? So as I mentioned, I'm Kim O'Neill, and today I'm here to share an early career perspective in health equity, and as well as some of my research exploring childhood influences on multiple sclerosis, or MS. I have no disclosures relevant to this talk. I just wanted to talk a little bit about my path on becoming a health equity researcher. It probably goes back to high school. I started as a volunteer in a Head Start classroom, and I really was so impressed by the children's stories in the classroom. And it struck me how early childhood could really have such a positive or sometimes adverse impact on a child's development and brain development early on in life. I was inspired to apply to medical school, which I did in Washington, D.C. And at the time, there was an option to graduate as a health justice scholar. So I took some extra coursework in patient advocacy, and we spent a couple days on the Hill advocating for patients. And that was a really great start to my kind of health equity path. I completed residency in the Bronx in New York, where a lot of my family grew up. And in both pediatrics and neurology, I was struck by how important the upstream social determinants of health played a role in everyday clinical care there. So it really stuck with me, and I continued on this path. I really enjoyed multiple sclerosis and neuroimmunology, so I continued with a fellowship in MS, a one-year clinical fellowship at NYU in New York. And at the same time, I wanted to continue learning and studying and researching the health inequities that I was seeing in clinical care. And I went on to complete a postdoctoral fellowship, so a 2-year fellowship, where I completed a master's in clinical research with a focus on health disparities and health equity research here at NYU. It was actually previously T32 sponsored, and they lost their funding. So my mentor, who is incredible, was able to help support me in getting that master's. And then I stayed on as an attending, as an assistant professor. I'm on a research track, so most of my time I spend working on research projects, applying for grants, writing papers. And I'm lucky to be a co-investigator currently on an NINDS grant, specifically a HERN initiative. So this is a community engaged health equity research and neuroscience. That was an RFA, request for applications from NINDS, and it's been a really positive experience so far. This is just a little bit about how I got to where I am today. I'd like to next talk a little bit about what I do clinically and in research. So I specialize in children that have neuroinflammatory disorders, or young people that have MS and other neuroinflammatory disorders like MS. MS is the leading cause of neurologic disability in young people, affects over 1 million individuals in the US. And pediatric onset MS is when this disease occurs before age 18. and it can occur in up to 5 to 10% of all MS cases. And what really struck me was how important early life environment is in the disease. We tend to think that there's no one gene that gives you MS, but maybe all the known genes and a family risk of autoimmunity accounts for 25%. There's a 25% genetic component, but 75% of a person's risk is probably environmental. And exposures before age 15 are especially key to later development of MS. And so I think kids may be key to understanding these exposures. They're temporally closer in time to childhood. They have fewer comorbidities and confounders, and I think it's a really important cohort to study. There has been some work in this area about how social drivers of health impact MS disease. So there's been a report of a rising incidence of MS and more aggressive MS disease among Black Americans, and Hispanic Americans may have a younger age of MS diagnosis and greater disability. And interestingly, when people looked at things like neighborhood factors, the patterns of Black race or Hispanic ethnicity are often attenuated in models that include individual social determinants of health markers or neighborhood level indicators. There was also some recent work in pediatric MS that showed families that experience social hardship. This is things like public insurance, no income households, or low maternal education, which has been used historically as a proxy for lower socioeconomic status. Families who experienced social hardship had children with earlier MS onset compared to families without social hardship. So there's a lot of really interesting work being done in MS. I also have an interest in childhood adversity. Most often, this refers to the adverse childhood experience, or the ACEs. These are potentially traumatic events such as abuse, neglect, that occur prior to age 18, and it's been shown across many studies to have a graded relationship with negative health outcomes and chronic disease. There's been some work in MS. A recent systematic review showed that a history of ACEs increased the risk for MS development and may lead to an earlier MS onset. So I'll start with one study we embarked on. We did want to look at things like childhood adversity and MS clinical outcomes. We, at NYU, at the MS Center, recruited 60 participants who were young adults living with MS, 30 of which had pediatric onset MS and 30 of which had adult onset MS. And participants completed questionnaires about their own childhood, such as ACEs and neighborhood information, and information about their current MS disease. At the same time, their MS neurologist, who was blinded to any questionnaire results, completed a neurologic exam and submitted an EDSS score, a measure of disability that they saw on exam. So shown here in a conceptual model, we created a childhood adversity score. So if they had any of the following, an ACEs score of 4 or above, a parent without a high school degree, or reported childhood income below the poverty level. And the outcomes we looked at were these patient-reported MS symptom scores, as well as their neurologist-reported disability scores. And this is some characteristics of our 60 participants. And you can see when we grouped participants who reported low childhood adversity, that was 26 participants, and high childhood adversity, 34 participants, they actually, demographics-wise, there were no significant differences, and they looked pretty similar. So the first question we asked was how MS symptoms impacted participants' everyday life. And you can see they can score from not affected at all to totally severe limitations impacting daily activities across many areas that are typically affected by MS, such as walking, fatigue, cognitive function, and others. So individuals with a history of childhood adversity reported an average MS symptom score of 15.12, compared with individuals who did not meet criteria for that childhood adversity score at 7.54, and this was significant. Participants that reported childhood adversity had significantly greater difficulty with walking, body pain, fatigue, depression, vision, and cognitive function. So certainly things that would impact people's day-to-day life. But what was most interesting, or additionally interesting, was when we asked their neurologists how they looked. So their neurologists, often we use this expanded disability scale, or EDSS, to rate MS disability from none to assistance with walking or even death, a scale of 0 to 10. And as expected, over 50% of participants had low disability, EDSS score of 0. This is pretty common in our young patients living with MS. But when looking at patients with some disability, so EDSS of 1 or more, the participants were 3 times more likely to report a history of childhood adversity, as shown here in these columns on the right. And when we looked specifically at pediatric onset multiple sclerosis group, not shown here, patients with disability were 7 times more likely to report a history of childhood adversity. So even objectively, their neurologists were ranking them as having greater disability than others. So when I think of these, in summary for this first study, we found that individuals who experience childhood adversity, things like the ACEs or proxies of disadvantage or poverty, they reported worse MS symptoms impacting their daily life. And additionally, their neurologists blinded to any of these questionnaires also reported greater neurologic disability on their neurologic exams. This was seen even early in the disease. So these patients had disease duration of 6 years or less, and it was a rather small sample size of 60. So we hypothesized that maybe childhood adversity can lead to things like allostatic load or weathering that many of us talk about and study. That makes it more difficult to recover from MS attacks or neuroinflammation, and maybe things like adversity wear down your resiliency to the effects of MS disease. These are all things we want to study more, but are really important to start talking about. So we embarked on a second study looking at the social determinants of health and MRI outcomes in MS. And we were interested in understanding how childhood social determinant of health factors, or SDOH factors, were associated with brain MRI outcomes in patients with pediatric onset MS. So we can kind of think of MS brain health by looking at some things on MRI. We can, shown here in the top image, see our typical MS white matter lesions and consider these, a proxy of inflammation. And we can also look at the bottom, our T1 sequences show black holes or actual tissue loss related to MS. And we could actually quantify these numbers and these volumes using volumetric software that could be added during a routine MRI scan. So we consider these rather real-world results of our patients just routinely being seen at clinic. So here was our study design. We underwent a chart review looking at things like childhood SDOH predictors such as self-reported race, ethnicity, parent education level, insurance status, and neighborhood deprivation using the social vulnerability index, using their address at time of MS diagnosis, and correlating it to MS outcomes, these white matter lesion volumes and black hole lesion volumes at time of first volume MRI scans. Again, we saw 138 participants with pediatric onset MS were eligible for the study. They had an average age at MS onset around 15, but by the time they were getting their volume scan, they were almost 20. They were rather diverse in terms of self-reported race, with over 50% reporting non-white race, 30% Hispanic race, ethnicity, and almost 60% without a college degree, and almost 50% on public insurance. And as we mentioned, they're young, they have very little disability. Their EDSS scores were a median of 0. So when looking at their social vulnerability index using their address at time of MS diagnosis, you can see very little neighborhood deprivation is shown on the left, scores of 0, up to scores of 1 or higher reported neighborhood deprivation. These are things that look at things like access to school and transportation, household crowding. So it's a larger index, but we had a diverse representation or a broad representation. We then wanted to take those individual SDOH predictors and put them in a model, a regression model accounting for things that we usually assess for in MS, such as disease duration, age, and sex. So you can see in this image, in this table, that Black race would be one model, Hispanic ethnicity would be one model, low parent education was a model, as well as public insurance and SVI. And the outcomes are shown here, white matter lesion volume and black hole lesion volume. And in these models, it seemed that each SDOH proxy was significantly correlated with white matter lesion volume and black hole lesion volume. This seems really important because often we see studies in neurology where one of these is tested, public insurance is tested, or neighborhood is tested, and they each seemed significantly correlated. And when looking at the coefficient size, it seemed like childhood neighborhood disadvantage, as measured by SVI, looks like it had the largest effect. And shown graphically, with SVI on the x-axis and lesion volume on the y-axis, first of white matter lesions and then black hole lesions, we can see as neighborhood disadvantage increased, so did lesion volume at time of first volumetric MRI. We then wanted to understand how all of these would interact in a model together. So we used linear regression models, or lasso models, which would select significant covariates shown for all of these things that were adjusted for. And when we put all of the SDOH predictors in one model, public insurance, which is considered a proxy of poverty, remained the only significant SDOH predictor. And MS is a multifactorial disease, so there's a lot of things that go into someone's risk. But when we assessed things such as the difference between someone's symptom onset and starting treatment, what type of treatment they were on, BMI or body mass index, smoking, disability scores, there were no significant differences between the SDOH indicators. So in summary, we analyzed associations between childhood SDOH factors and brain MRI outcomes in patients with pediatric onset MS. We found multiple SDOH variables appeared to correlate with MS MRI outcomes, but poverty through the proxy of public insurance remained the most significant in multivariable models. And I think this reminds us it's important to examine many aspects of these social determinants. They're just proxies, they're imperfect ways to measure things we're seeing in society, but they're also interrelated. And so it's important to look at multiple of them when understanding their potential impact on neurologic disease. We also saw individuals with public insurance had greater burden of inflammation and tissue loss. Even early in their disease, these patients were almost only 20. Again, reminding us maybe there's some burden of social stress that may impact resiliency to MS inflammation and injury, and is just so important to understand better. So overall conclusions for this early work that our team has been looking into. Among all MS patients, we saw greater adversity in childhood was associated with greater MS symptoms in adulthood and greater MS disability. This was most notable among patients with pediatric onset MS who are closer in time to these childhood exposures. And then when looking at individuals with pediatric onset MS alone, we found social determinant proxies were associated with greater neuroinflammation and brain tissue loss in adulthood. and neighborhood and poverty stood out as the most severe factors. This is not new findings. These have been seen across other neurologic diseases and really just underscores our need to take actionable steps to address upstream determinants of health early in life. There's a large team who works on this, and I've had many incredible mentors here at NYU. So I just wanted to say thank you to my mentors and our research team, and of course, our wonderful, wonderful patients and families. And in the spirit of today's talk, I also just wanted to add some thoughts about embarking on an early career in health equity and some advice I would give people starting out in this area. I think supportive mentors have really been so key to my early work success and really helped me get to where I am today. I think thinking about opportunities for your CV. So I was invited to present at the AAN Health Equity Day. There's also a healthcare equity program that people can apply to. And then my hospital at NYU has a health equity institute. So I've been meeting with them regularly, going to conferences, and was an invited speaker there. I also applied to an NIH Health Disparities Research Institute, which was really incredible. And I got to go to NIH and meet other researchers in this area. It's so important to share your work at conferences and grand rounds, and that's really how you meet people and people get to know you as a health equity researcher. At conferences, be sure to seek out similar projects in health equity, even in different fields. If someone's doing something interesting in stroke or in dementia, you should talk to them and idea share because it's all very overlapping and important. And finding health equity mentors that can even be at outside institutions. As someone early career, you could even offer to co-author a paper together or write a position piece to start getting your name in the space. And if you're embarking on a full research career that will be grant supported, you could consider diversifying your funding. Not every grant you submit necessarily has to be health equity. It might be a passion project. Um, and it could be one project and other projects could complement your work in a different way. And just begin. It's so important. We need more people in this field, and you really only need one or two interesting projects to get started, to start talking about. And it's always the right time to just jump in and start. Thank you so much.